that you asked me to present, and I'm actually really thankful that you see me as being able to share our experiences at Cherokee Nation. So let me share my screen. Hello, everybody. I see a bunch of people. I wasn't sure if anybody was going to show up given the situation now, so it's really good to see some faces like Larry and Dawn. So, hi. All right, let me share my screen. Okay, so basically, I guess I'll just go through the PowerPoint, and then if you have any questions, just save them until the end. I guess that would work. Shannon, yeah? Okay.
Yes, yeah, that would be great.
All right, so my name is Tonya Wapskineh. I work with Cherokee Nation. I've been the diabetes prevention coordinator since 2005. We were given the SDPI funds for the diabetes prevention part of implementation that was derived from the national study that was implemented saying that diabetes may be prevented through lifestyle, or was a study done where it was trying to prove that it could be prevented through lifestyle. And so that was the portion of what we were doing within Indian country. So we've been doing our program since 2005, and I'll give you some information that we have a 14 county tribal jurisdiction in Northeast Oklahoma, and it's about 7,000 area miles, and within that we have 8 Cherokee Nation clinics, an employee clinic, our own hospital, and then we also have an IHS hospital within our location. And this is basically what it looks like on a map. Can you see my mouse? Yes, okay.
Yeah.
So Tahlequah is right here, and that's where our big hospital is, right there. And then the plus signs, those are our clinics. So to get to some of these areas, it could be an hour to an hour and a half, some 2 hours, because we do have a satellite office up here in Bartlesville. And then we have the Claremore Indian Hospital here. And then we all, this is about an hour away. This is our Redbird Smith Health Center. And you can see right here where we take up the northeast corner of Oklahoma. So whenever we began, we started with the IHS program, and then that program subsided in 2016. And so we were given funds through IHS to still continue with our diabetes prevention efforts because of the success that we had within our communities and with our tribal members. And at that time, it was actually recommended to us from the our grantors to apply for the CDC DPRP program, which is the Diabetes Prevention Recognition Program. And so we decided to do that in 2016. And then now we are at full status as a DPRP program. So what we do is we utilize the CDC curriculum, and the CDC curriculum, I'll talk a little bit more about it in just a little bit, but it wasn't anything different than what we were already doing. Just the format was just a little bit different, but it was still the same information. So we were used to doing that for 10 years. So we decided to go ahead and continue with that curriculum. When you do apply for the CDC DPRP program, you are automatically given a 2-year pending status. So that basically gives you the time to recruit participants, have classes, turn in your data, and then after 2 years, then CDC will be able to give you a different status, whether that be full status or preliminary status if you weren't able to meet some guidelines. So we submit data every 6 months, and it's really based on attendance, how many people came to the classes, which is month 1 through 6. We call it our core class. So months 1 through 6 is the core classes, and then they also look at the attendance for months 7 through 12. So we went from like a 4-month program to basically a 12-month program. So it was really difficult, and we're still learning how to retain that many people for that long. So we're still kind of like in this learning process as well. But today, hopefully I can share with you some things that we've learned since 2016 to keep people in a year-long program. So the 6-month data submission is also, they look at the documentation of body weight and physical activity minutes. So say every time somebody comes to your class, you record their body weight, and then you also record their physical activity minutes. And if you do this with everybody that's in your program and throughout the whole 12 months, then you're given a 100% score. And then they also look at the average weight loss, and the goal is 5%. And this is what you have to achieve in order to get that full status. And then 35% of your participants have to have prediabetes. They have to have that diagnosis, or they have to have a history of gestational diabetes. So with Cherokee Nation, what we decided to do, because whenever we were with DP, which was through IHS, whenever we were kind of given free reins, I guess, on our program, and we were looking at CDC as well, we wanted it to be open to everybody. We didn't want to eliminate anybody from coming through, because with DP, it could only be participants that had a diagnosis of prediabetes, and that was the only eligibility requirement that really gave us a hard time to work with anybody with. So, and we felt that anybody from the age of 18 on up should be able to get that information and should be able to come to the classes. So that's basically what we decided to do with CDC. So it would be up to your organization how you want to do that. And we basically see everybody, but we do have to do it within the with the guidelines of the CDC. So let me move on. Okay, so why utilize the CDC curriculum? There's 2 types of curriculum that they offer, and the type that we use is the 2012 CDC curriculum. And this is actually adapted from the initial study that was done through NIH, NIDK, and was done, I believe, in 1990s. And then we've already been using this in Native communities, and with all the data that was pulled together through DP, we still had the same results as the national study within our communities, that we were preventing diabetes. So we went ahead and stuck with the same curriculum that we were using, because it was effective, and it also holds our participants to be more accountable. So we wanted to keep that. Also, as far as applying and utilizing the curriculum, the full status, it may help with future funding. I'm not sure if, I think it may have helped us in some ways, but I'm not going to say, you know, if you do this, you're going to receive funding. I don't want to say that, but I think that if anything was to come through for diabetes prevention, I think having this status would actually help your program, just because of things that I've seen as far as other grants that have come out and through CDC, and if you're already implementing the DPRP, it'll, I think it's a positive thing to have in your community. Also, it was recommended by the Indian Health Service Diabetes Program. So getting started, whenever we were talking, or whenever I was talking with Shannon, that was one of the things that she wanted me to share is how did we start this? So basically, what we had to do, it was gain stakeholder support. We had to develop a data collection system because it's all about data. You want your data to be, it's really the most important piece as far as your program, like programmatics, because this shows that if your program's working or not. And then you want to identify and train coaches, you want to recruit participants, you want to implement your program activities, and then be an effective coach. And I'll actually break this down. So gaining stakeholder support, this is what we did. We created an advisory board. Cherokee Nation, when I came in 2005, they had a metabolic syndrome program that they were piloting. So it was something that they were already looking at for diabetes prevention. So whenever we got the grant, it was kind of not easy, but there was already a group of people that were already interested. So we worked with tribal leaders, and we worked with healthcare professionals and other people that were in Cherokee Nation system to help us with what they did in the metabolic syndrome program, so then we could work with them for diabetes prevention. So with that, we were able to gain support from our elected officials. Sorry, my dog's in here. Elected officials and clinic directors and our staff. So because I was brand new, I came from the Association of American Indian Physicians, and although this is my tribe and my mom's community, I did not grow up here in Tahlequah or northeastern Oklahoma. I grew up in the middle of Oklahoma. So it was still new for me, and creating the advisory board actually helped me learn more about our community and learn what is already happening. So for those that are new to your organizations, it's a great way to get information and to meet people and to kind of be on the same page about where the direction of where the tribe wants to go and your health programs. What also helped was we scheduled frequent meetings. We met once a month with the advisory board to plan how we were going to do this, how we were going to implement the diabetes program. And then after that, like after the meetings, we would communicate weekly. I would always send out something like, this is what I'm doing, or, you know, so-and-so, were you able to check on this? So we still had communication throughout the month. And I know a lot of times when you start a program, you have a big meeting, and then sometimes it just kind of goes away, you know, because people get busy and it's not really, so the job for me was to kind of stay at the forefront on that, so then nobody forgot that this is what we're doing. And because everybody's busy, everybody has a lot of other things that they have to do, especially in health. We wear a lot of different hats and we have to do a lot of different things. Also, we started hosting community activities, and we became visible that way in order to let people know that this was coming down the pipeline, that we were going to be doing a diabetes prevention program. So it wasn't necessarily in the diabetes. So where we were was like balance between clinical and community, and we're like right in the middle of that. So to show them that this was a new program and this is what we're doing, being in those communities is what really helped us whenever we were ready to start recruiting. So as far as your data collection, we always start with this in public health and here at Cherokee Nation, is how are you going to actually collect your data? What questions do you want to ask? What's going to be the most effective way to report? And how's this information going to help with your future funding? And then what do you want the end result to be? So asking your staff those questions, asking your advisory board those questions, and then coming up with your own guideline with CDC guidelines or whatever guidelines you're working with, but what do you want for your organization? What do you want for your tribe? Because this is our information, and even though CDC has us collect, you know, weights and physical activity minutes, we still collect a lot more information than what is required, because this is something that we can give back to our tribe. This is something that we can let our directors and our chief and executive board, that we can let them know exactly what we're doing and how people are actually changing their lives by being in the diabetes prevention program. And it's not necessarily in those numbers sometimes, but it's in the qualitative data. And even just like statements from our participants, we keep those and collect them. So then, it's because it's our mark in history, if you will, that we're doing this and this is what we've tried. And we have years of data collection. So it's really important to ask yourself those questions for your programs of what is important to you and something that you want to keep, and what's important to your tribe, and what do you want your tribe to know as far as future funding. And so now, say, Indian Health Service wasn't able to fund us, well, we have all this data, we can take it to our chief and say it works, and here's the information, and then hopefully they would still fund our program even if we weren't grant funded. And then also establish how data will be collected, what forms will you need, and then staff, if you have the money to do that, if you are able to hire someone. So right now in our program, we have actually 4 people that are in the diabetes prevention program staff. That's myself as a coordinator, and then I have 2 coach coordinators, and then I have a data entry tech. So basically her job is just to upload data to various different Excel spreadsheets, and that's what she does. So, and we needed her because we have a lot of people that we see. All right, so recruitment methods, like where do you find your people? How do you get them involved? What we did was with that advisory board, we also developed our eligibility guidelines. So it did change from the IHS STP-IDP program whenever we started looking at the CDC guidelines and whenever we started applying for CDC DPRP. So our guidelines are basically the same as CDC. Excuse me. So we recruit anybody that is at high risk for the program. And even though there's a 25, so BMI has to be 25 or more, we have people that come in with a lower BMI, but we still keep them in the program because we don't want to turn anybody away. We just don't send that information to CDC. Sorry, CDC. But we feel that, they're our community members, and if they want the information, we're going to help them. And our funding is through IHS, so we're still able to see them. So we basically report to IHS, and then we report to CDC. So we don't want to turn anybody away. So your eligibility requirements may look a little bit different, and that's okay, just as long as when you're applying for CDC, DPRP, that you're still making sure the participants that you submit meet those requirements. And then identify eligible community members and patients. So this was one of the things that we had a hard time with in the beginning. Like, how do we do this? Where do we find these people? Because you can't just go up to people and say, oh, do you have prediabetes? So what we did, we started screening in our communities, like at basketball games or parent-teacher conferences at the schools, because those are really huge in our small communities. Everybody comes together for family reunions or hog fries or something like that. And so we were able to go and just set up a table and start recruiting people, and just to see if they would be interested. We would give them something really small, like an incentive, like classes or a fan or something that just something small to where they would fill out the questionnaire. If they were interested, then they could put their information on there. And then we also did lab screenings through the clinic, and that took some effort to work with the clinics. We would have to go out to all the clinics and let them know about our program, and then let them know the participants that we were looking for, which is their patients, and also kind of gain their trust. That was really important because those are their patients. And here we are kind of coming in and not really being from that community. So they had to trust us that we were going to do the best possible intervention with their participants or their patients, and let them know that, we're not taking over care, or we're not trying to take anything away from their medical treatment. What we're doing is basically providing a supplemental program so then they can prevent diabetes, and it just adds to their prediabetes treatment or history if they've had gestational diabetes, so then to help them prevent diabetes. The lab screenings, if they were needed, then working with your clinic administrators and your healthcare providers, that also helped, because for CDC, you have to have some type of way to distinguish or to see what their blood sugar level is for those that have prediabetes, and to send that information on. Also, we contacted eligible participants to recruit through letters and emails, and we were also very proactive in our publications. So Cherokee Nation, we have a newspaper, we have an online presence, we do social media. So we used every avenue we could think of to let them know about our program. As far as referrals, I wanted to go back to this. So with Cherokee Nation, what we did with our referrals is, so we were in the program at the very beginning, and we were out trying to recruit people in the communities. Well, we weren't getting very many people. We weren't getting the numbers that we wanted. And so that became kind of an issue, because at that time we were funded through IHS. So what we did was we started working with one of the clinics, and that's whenever we went in, we talked to them, let them know what we're doing. And we had more success with referrals than we did with the community screenings. And that may be the same, for anybody else, but or maybe it doesn't work, but the referrals, it really did. Our numbers went from like 12 to like 60. So it was a huge, tremendous help for us. And so our referrals, and this is probably different from your health systems, but our prediabetes referrals, and then even those that have gestational diabetes, they go to our dietitians. So we were able to work strongly with the dietitians, and then the dietitians would send the referrals over to our program. So then we can contact them through a letter to let them know this is a program that we're offering. If you're interested, please call us and let us know you've been referred by your dietitian at so-and-so clinic. So so you kind of really had to find those clinic providers to see who are getting those referrals for education, patient education, and for prediabetes and GDM, and then ask them, to share that information with you. And see, Cherokee Nation's like interconnected with all the health systems and even with the hospital. And I know that with IHS, the Claremore IHS hospital that we have in our jurisdiction, they're not able to share information with us. And I know that happens in other communities as well. If there's an IHS hospital and then you have the tribe right there, getting that information is difficult. I've previous to working here, I also worked with Pawnee Indian Health Systems and the tribe, and it was really hard to work with the people that had diabetes because IHS wasn't able to share that information. So we had to get really creative in trying to find, okay, well, we know that they go on Tuesdays to pick up their supplies, so let's offer something on Tuesdays, like a booth outside or something to where we're visible, and then we can catch them and then try to help them through our program as well. We developed a master registry, and this helps with data. And so any referrals that we get, it goes directly to the master registry. And that way people aren't necessarily ready when we send them a letter. And we keep sending letters and they probably get tired of us, but sometimes it works. And after, 2 years, then getting maybe like 10 letters, then we have had participants come in through the program with us, just keep trying to stay in contact and keep recruiting them. I think we only had 2 people call to tell us to take us off their list. And so that's not a very many compared to how many people we've tried to contact throughout the years. So I would just say, just to, when they're ready, they'll be ready, but they need to know that they have somewhere to go. All right, so successful referral activities that we did. We did a provider challenge in one of our clinics, actually in 3 of our clinics, just because we weren't getting the referrals and we weren't having classes in that area. So we set up provider challenges. So whoever sent the most referrals, then they got like a t-shirt, or in our previous funds, we were able to provide food, and that goes far for providers. So we gave them like a Subway lunch, and their team won, because our clinics, they set up their clinics in teams. So it's like gray team, red team, whatever. And so providers get really competitive. And so this was a great way for them to start sending referrals in, and we would let everybody know, like, this doctor and their team won for the provider challenge. And so it made them feel good. So, and it gave us a whole bunch of referrals, so it was great. And then also gaining support early. Like I said, we went out into the clinics early and met with the clinic administrators. And then we also sought provider input when we did meet with them, because like I said, we're not trying to, take over their program or take over their care. So we want them to know that they can let us know what they want from us, and then we'll be able to provide that. And then we always go back to the clinic and give them updates, like, this is what's happening with your patients, and this is, what's going on with our program. So the communication still has to stay well connected. Okay, retention. This is also another one. Like I said, when we first started doing diabetes prevention curriculum classes, they were 4 months, and now it's a year. So it's very different as far as our retention and the things that we're able to do. And plus, we don't have the funding that we did before. We used to be able to get incentives like every time they stepped through the door. If they were doing a physical, we gave them something. If they filled out a questionnaire, we gave them something. So now we don't have the budget to do that. So we had to get really creative in how we were going to keep people in the program. And we're still learning. It's still something that our retention rates just aren't what they were before, but you are looking at a 4-month program compared to a 12-month program. So what we did with our classes was instead of just doing the minimum classes that are required, and I can't remember what that is right off the top of my head. I have it right here, but I can't remember. But what we did was we decided to do 1 class a week for 16 weeks. So that's month 1 through 4. And then in month 5 and 6, which counts for your first 6 months, then we went to bi-weekly. So they go through the classes weekly, and then they go for 2 months bi-weekly, and then months 7 through 12, we do 1-month classes. And that's usually when we start seeing people starting to drop out. Like, they do really great for the weekly classes. If they're there every week and they're showing up, they do a really good job. But when you start moving it to bi-weekly and then monthly, then it's almost like they forget about the program and what they're doing. So we try to have our coaches start a text message, like text messaging, group messaging, to let everybody know, give them reminders, or a group email, or to keep them together somewhat, and then communicate that way. And we also make our participants accountable. So as far as having them show up, like for instance, some classes, they have money in their clinic to offer something. So I think one of them has like a Fitbit watch that they're able to do if you come to so many, and then there's a drawing that they'll do for that Fitbit watch. So finding different ways to keep your participants in the program and coming. And then the incentives, what we do is, I think we have like 8 incentives right now, but we did recently get the GWIC through, so we're working with Healthy Nation on that. So we'll be able to give them a little bit more supplies, is what we call them, as supplies, because it's like a weight scale or a George Foreman grill and things like that. So I will say this, as far as the supplies, the things that, when we did a survey with our past participants, we wanted to know what a supply item helped them the most. For physical activity, the #1 supply was a pedometer. And as far as the nutrition, it was portion plates or portion containers. And then also a George Foreman grill was actually one of those too. So there were 3 different types of things that they thought that it helped them. And also the keeping track books, and then the Calorie King book, and which I'll kind of talk about in just a second too. And then so that was another way to keep them in the classes. And then we also use our own Cherokee Nation examples as far as activities and foods, things that we have here in our community, and things that we eat here, and the tribal games that we play here, our Cherokee games that we do. We give, we add that modification to the curriculum, and we even will play, if people are willing to do that. And so we set up different times for, we allow our coaches kind of just to do whatever the participants want. And you'll notice after you start implementing the DPP classes that each group is not the same. One group could be very talkative and full of ideas, and let's do this and let's do that. And then another group is completely silent and they don't talk, and they're fine with going home, but then they're still doing really good in making their weight changes and meeting their nutrition not requirements, their nutritional goals. And then we use group facilitation techniques. If you are to do the DPRP, that is something that you'll be trained on. And I'm actually a master trainer for that. And so I do love that portion of the CDC training that is provided through DTAC and other entities, but because it is a group facilitation, and that was something that we weren't taught before. And so it basically teaches us that our job isn't to tell people what to do. We're not there to give the curriculum and just read it word for word, like just have your curriculum here and then just reading it, because participants, they're not going to learn that way. So what we do is we facilitate discussions, basically. So it's almost like you're a coach facilitator. You're not really a teacher, but you're a facilitator. And people usually come out learning more that way because they're able to, talk to each other. And say somebody is struggling with cutting out on soda, and so then another person may have been able to overcome that. So then they have a group discussion, and then everybody's talking, and then that person that's struggling comes away with a whole bunch of ideas on how to, to eliminate their soda consumption. So, and sometimes it's just, basically just having their classmates or their peers give them that information, and it seems to work better than if I was to sit there and this is what you need to do. I mean, we all know, like, we're, I'm sure we come from like health backgrounds or some sort of education where we can just go up and say this is what you should do, but to open back up to the classroom and have them talk about it, then it almost seems like it resonates more with the participants. So this is our #1 tool, and there's actually scientific research that proves that food journaling is the #1 success tool in trying to accomplish any like nutritional goals. And so this is a picture of one of our past participants, and as you can see on the table right here, she has the keeping track book. And this is something that we give out to our participants. And then she has, whoops. And then right here, the book that she has in her hand is the Calorie King book. And we're able to order that through Amazon. And it shows basically, if you're not familiar with it, it just shows you how many fat or how many calories are in your food. And then you keep track of that. And then we were able to give them calculators. And then right here, this was something that we were able to give away in our last, when we had money, but we were able to give this away, and it keeps it all nice and neat. And they actually love the Pendleton planners. So if you have money to do that, the Pendleton planners are a great idea. And I can't remember what group did that, but we learned this from another group that was part of the SDPI program. So learning from other communities, and since you guys are part of Great Plains, you guys can always, feed off of each other and get ideas from each other, and hopefully that will help. And then being an effective coach and team, that has also helped with our retention. So like I said before, we're not really there to be the teacher. We're there to be a coach. We're there to be a facilitator, a support person. And that developing the relationship between you and that participant, that's going to be your #1 retention right there. Because if you develop that relationship early on, and they trust you, and they know that you're going to be there for them to help them with their behavior change, they're going to do really well in the program. They're going to want to stay. They're going to feel bad if they miss, and they'll contact you. So earning that trust and developing that relationship, I say this to everybody, is that's the most important thing that you can do as a coach, as a facilitator. Always stay positive. Whenever I run through the training, we don't look at the negatives in their keeping track books. We always try to stay positive, even in our conversations, staying positive. We don't criticize them and say, what, you had 10 fry breads? Are you crazy? We don't talk bad. We don't talk down to anybody. So we just try to make the conversation always a good conversation. And if people want to bring in negativity, then it's quickly diverted to something else. And so, because we're trying, that's our job, is to facilitate the conversations. As a coach, be available and help solve. So our expert advice, try to keep it at bay, and then have them come up with something that works for them, because our lives are totally different from our participants' lives. And even another coach's life would be different from another coach's life. So what works for me wouldn't work for somebody else. And we have to keep that in mind, and to have them, okay, well, let's see what you're doing. How can we fit in more activity? Let's see what your schedule looks like. Okay, you're a morning person. I'm not a morning person. I'm an evening person. So if I was to tell people to start working out from 8 to 9, that doesn't fit to somebody that's in bed at 8, you know? So you always have to work with them individually and regularly to help them solve what they need help with. And then provide support, which is mainly listening, not some. And I feel weird because I'm talking so much right now. I don't usually talk this much, but just listening to them is usually what they want. And then establish your team. So this is our team right here. And actually this Debbie right here, she's no longer here. So, and with the reduction in our funding, we miss her, but we can't afford her. So we had to move on to, here's our data entry person, and then our 2 coach core. And they've actually been with me. So Jennifer here and Karen, they've been with me since 2005. And then Carrie, I want to say she started in 2000. No, it had to been like 2012. So so we did have like 1 turnover, but everybody pretty much, this whole group has been with me since 2005. So I think that keeping your team together really helps, because then you don't, I mean, it just makes it so much better, because you don't have to retrain anybody, and you already know they know what to expect from the job. They know how to do their job, and you just give them the tools, and they'll do it, you know, and you just give them the ability to work with their passion. So my goal is with our team is to work together as a team with common purpose and passion to heal our community. And that's something that we work towards all the time. We're all very passionate about making diabetes go away. It's horrible. So it affects, you know, everyone, and especially with the virus out now, I mean, they're doubly affected now, and that's not something that we want, and that's not something that we want to happen in our tribal community. So having that passion, that's what you need to see when you find your team. And then we're able to develop and implement and problem solve together. So even though I'm their supervisor, we work together as a team. I don't have this boss to staff relationship. We have a team relationship, and and I do just as much work as they do, and they know that they can trust me to do the work, you know, that I'm doing the same thing that they're doing. And then so we're able to if there was something like a barrier or something come up with one of our classes somewhere, then we can all work together to help that community and help, you know, that program. And then also give praise, never criticize your own team, and then support each other, and then try to reduce staff turnover. Like I said, like most of my team has been with me since 2005. So I'm very thankful for that. And I'm very grateful to have such a great team to stay with me for so long. And then successful strategies, and I'm almost over. So successful strategies, utilize a timeline. So when do you want to start your classes? How much time are you going to need to develop the materials? How much time are you going to need to go out into the clinic and meet with the providers? Or is there a big not celebration, is there a big, like for instance, here we have Cherokee Nation holidays, and tons of people come from all over the place, and it's during Labor Day weekend. So maybe something like that happens in your communities where a lot of people come. Well, maybe you can host like a walk or a run or an activity, and then let them, you know, have informations for diabetes prevention, and then that way they can have your contact information. So just seeing what's happening in your community already, and then trying to utilize that within your recruitment and when you want to start classes. And then plan some more. You can never stop planning. communicate with the team, whether that be your advisory team, your staff team, your DPP team. We have a DPP team as well, Diabetes Prevention Program team, and we meet with other people within the health system, and then the clinic team. So we actually have a lot of teams with here at Cherokee Nation, but I think it's because we're such a large program. And then develop effective logs and forms. Make sure with Cherokee Nation, we had to go through, we also have our own IRB. So we had to make sure that was all set up before we did anything. So if that's at your tribe, you just might want to put that in your timeline to make sure that your program is good to go, and all the logs and forms, they've gone through QI. They have the necessary documentation on them to say that you can, use it in your program. And then great relationships with your participants. I cannot say that enough, so that's why I had to put that back in there. And then also piggyback community events for exposure. So like what I said about our Cherokee Nation holiday, piggyback on some other community events. Like we would go out and set up for basketball games, parent teacher conferences. They don't really do health fairs as much here, but I think in other communities they do. So like not at Cherokee Nation, but across the US. So maybe if you guys are having a health fair, then setting up there. Be visible. That is number one thing. If you're starting a new program, utilize the media outlets, your social media, and then always be an example. Represent your work and the goals of DPP. Be positive, live healthy, and because your work speaks through you. So if you're active and people see that, or like coworkers, if you're eating healthy lunches every day, then they'll want to do the same thing. And we do get a lot of people that are actually employees of Cherokee Nation and even employees of our health clinics. So just being an example to your community is something that also helps your program. But other than that, and I appreciate you again for asking me to present, and thanks for bearing with me. This is my first Zoom presentation, so it's really weird not to see anybody. I just see my presentation, so thank you again.
Thank you, Tonya. We really appreciate you getting on with us today. If anyone has any questions for Tonya, feel free to unmute yourself now and ask your question. You can also type in the chat box and I can read that out for you as well.
Let's get down. Never mind.
And I do have a question in the chat, Tonya. Do you provide incentives other than the meals for meetings to the providers that won the referral challenge?
So when we weren't able to do the meals, we have t-shirts, program t-shirts that we designed and had made. And so our community does a lot for t-shirts, even our providers. And so that was one thing that worked, was having a t-shirt for everybody. And the team is maybe only like 6 to 7 people. So it's not like it has to be anything huge. I think just sending the email saying this team won, I think that was enough for them.
Okay, if anyone else has any questions, we are going to stay on for a little bit longer. And I did put a survey or a evaluation survey in the chat box if you have time to fill that out for us. And just a reminder, this is recorded, so a follow-up email will be sent out with the recording in case anyone on your staff or might not be able to join today. And then I also want to let everyone know to keep a lookout for next month's webinar, which is on May 13th. And we're doing a physical activity themed webinar through traditional dance. So we're really excited for that one. So keep a lookout for that invite. Again, we'll stay on a little bit longer if anyone else has any other questions. Otherwise, thank you so much for joining us today. Hope you all are staying healthy, and we'll see you on next month's webinar. And thank you again, Tonya. That was a great presentation.
Thank you.